Good afternoon, friends. Today my talk is about an endemic problem, that of multimorbidity. Dr. Pati has given an excellent overview of this problem in the community and its implications during COVID, and we will now focus on some of the aspects of multimorbidity at our tertiary care center. The definition of multimorbidity has been undergoing changes. It is currently defined as the coexistence of two or more chronic conditions in the same person. So why is this a problem in India? The elderly in our population are increasing, and multimorbidity increases with age. From the early 2000s to today, there has been an increase in the decadal growth rate of our elderly, and it's projected only to increase further. Our southern states have a higher proportion of the elderly, and so also a higher proportion of multimorbidity. The overall prevalence of multimorbidity in India is around 23%, with Kerala in the south and Punjab in the north having the highest prevalence. Should this bother us physicians? Let's take a closer look to answer some of these questions. Though classically described as a problem of the elderly, in some recent work done in Kerala, the prevalence of multimorbidity in the productive age group was as high as 45%, with diabetes, hypertension, ischemic heart disease, and occasionally depression being the common clusters. So 1/3 of our productive population has two or more chronic conditions, and this seems to be worse in women. We have an aging population, an unhealthy middle-aged population. How are we equipped to handle it? Well, we aren't. This was clear during the COVID-19 pandemic and can be understood with a closer look at our healthcare organization. Our healthcare system has a public and a private arm. The public arm is organized in a tiered way with a referral system in place from the primary to the tertiary level. But only 1.8% of our GDP is spent on this system. This leads to inadequate coverage of the masses who then turn to the private sector. The private sector in India is largely unregulated and is not tiered. This leaves the patient to decide what level of care he or she must access. So those with multiple chronic diseases end up going to various doctors, oftentimes at a tertiary health center like ours. So multimorbidity is a growing problem at tertiary hospitals as well, and it leads to fragmented care. So yes, we must address this problem. I would like to now invite Dr. Esther to present the magnitude of this problem facing the Department of Internal Medicine here at CMC.
Thank you, Dr. Tina. Good evening, friends. Now I'll be presenting the data on multimorbidity from our center, which is part of the dissertation process done by 3 of our PGs. OPD, ICU, and inpatient referrals are 3 important clinical areas where we are involved in caring for patients with multimorbidity. And we see that 5th to 6th decade is the average age of the patients with multimorbidity to whom we cater to in these areas. We also found that more than half of our patients are women. The most common combination of morbidities among our patients was diabetes and hypertension. Even so, about 20% of them visit more than 2 specialty OPDs for their care. We found that 1/3 of our patients who require inpatient referral to a physician are multimorbids, and among them, 1/3 of them the reason for referral was for perioperative optimization. We also compared our data to our neighboring state, Kerala, which also has high prevalence of multimorbidity among the population. We find that the results are similar. The prevalence increases above the age of 50, and there are more proportion of women, and the most common diet there was also diabetes and hypertension. However, in a study done in Orissa, done by Dr. Sangamitra, we saw a similar age group and gender distribution among the patients with multimorbidity, but The common diet consisted of acid peptic disease and hypertension. So the inferences we can draw from the data at our center are that multimorbidity is common and affects our middle-aged adults, women more than men, and our common diet is diabetes and hypertension. Even so, there is fragmentation with patients visiting multiple specialty OPDs. Multimorbidity also contributes to referrals to medicine. So it is clear that it is a problem at tertiary care centers as well. However, the spectrum of diseases is different. This emphasizes the need for tailored research in this area.
Thank you, Esther. We will now take a minute to look at what the day in the life of a multimorbidity patient who visits CMC in OPD looks like. So a closer look at the problems of the multimorbid show us that the lack of a tiered system coupled with single disease guidelines leads to multiple referrals. We all are familiar with the image on the right, with a single patient having to visit multiple specialists. The result of these multiple referrals is polypharmacy, which is the use of more than 5 medicines in a single individual. This may lead to multiple problems of its own. So the string of issues leads to an economic impact that is incapacitating to the poor. Grace et al. Found that those with 2 or more chronic diseases spend 2.42% of their mean annual household disposable income on medicines. This can lead to families having catastrophic health expenses and getting pushed down below the poverty line. So why are there no guidelines for the multimorbid? A systematic review on ongoing RCTs has shown that most studies exclude them. In addition, multimorbidity clusters are complex, with interventions needed for each cluster. A 12-year cohort of more than 3,000 elderly in Sweden shows how there are numerous clusters of chronic diseases and also how they evolve over time from one cluster to another. Thus, research in this field can be quite unwieldy, however, is urgent to help make guidelines. The lack of a well-organized healthcare system, a lack of guidelines, referrals, and overcrowding of specialist OPDs leads to a lack of time given to the patient. A systematic review of 67 countries looking at the time for consultations found that India ranked 6th from the bottom. It was estimated that a physician spends less than 5 minutes per patient. So it comes as no surprise that the quality of life of those living with multiple chronic conditions is poor and is inversely proportional to the number of morbidities they have. On the other side of the equation are the doctors. The doctors face an increasing amount of burnout. In Denmark, the prevalence of physician burnout was proportional to the number of morbidities their patients had. So we can only imagine the state of our own physicians. So what is the way forward? Awareness is the first step. Thanks to the efforts of some, the problems of multimorbidity are coming to light. As it is a complex problem and is intertwined with the social determinants of health, interventions need to be tailored to the outcomes of interest to these patients. We need to design interventions that make sense to them and hence be involved actively in research planning. Hopefully, such research can guide physicians better in their objectives of giving meaningful and cost-conscious care to their multimorbid patients. So that brings us to the end of my talk. I would like to end by thanking Professor Tambu David for all his encouragement and support towards this work, my colleague Dr. Esther, and our 3 PGs Dr. Joel, Sonia and Sahil, who have been working as part of their dissertation on multimorbidity, whose work was presented here. Thank you.